I hope that this presentation will give you some new suggestion to afford this new era for dentistry, because the COVID-19 has changed everything, and so our practice should be adjusted to the new profile of the patient that has come. And so we can start talking about how to use residual roots in the mouth of our patients. Okay. This is where we are coming from, Bologna, of course, in the middle of Italy. And now let's start to talk about when you decide to extract a residual root of a tooth. So first of all, we have to take care to make a good diagnosis. So when a tooth is good, when hopeless, and when questionable, we have a very clear idea when a tooth is good to take. And also we have a very clear idea when a tooth is hopeless and ready to be extracted. But there are many situations in which our residual roots are questionable. We are not, there is not 100% going to the extraction, neither to the maintaining the residual roots. And I'm going to talk exactly about this kind of roots. What can we do with questionable roots? And so when do we consider a tooth hopeless? So when we are obliged to extract a tooth? When we have persistent and symptomatic endo lesion after several retreatments, it's impossible to get out from this granuloma or infection. When we have severe periodontitis, of course, this root has lost more than 70% of its length, so this tooth is ready to be extracted. When we have severe loss of our tissue due to fracture or decay, and there is no more hard tissue remained in the teeth to permit us to make a good reconstruction. When the root is fractured, of course, the fracture of the tooth is not replaceable anymore. And when we have combination of everything, of all the previous steps we mentioned, so periodontal problem, severe loss of hard tissue, and periodontal problem. And when it is irrational to keep, this is a severe loss of our tissue in a delicate zone to restore. So this residual root is eligible for extraction. We have to keep in mind that the tooth has two vital parts. One is the endodontic part, the nerve or the pulp inside it. And the periodontal ligament is a very important part of the teeth of the root, because in the periodontal ligament there are receptors, and receptors allow the tooth and the nervous system to record the sense of touch, pressure, and pain. And the periodontal ligament contains proprioceptors giving information concerning movement and position of the mandible. This means that the tooth is not only a mechanical instrument, a mechanical organ, but it is a sensitive organ. And it's in the periodontal ligament we have a different kind of corpuscles, like Meissner corpuscles or Ruffini receptors, that give us the sense of touch and pressure, and the free end fibers that gives us the sense of pain. All these nervous system, nervous terminals are connected with the muscle centers, in the central nervous system. And mechanoreceptors are activated by tooth movement, as little as 1 to 3 microns. So it's a very, very sensitive sensory proprioceptor. the periodontal ligament efficiently encode the occlusal load. There are several demonstrations that the signals from periodontal ligaments, together with proprioceptors in muscles and tendons from the masticatory muscles, play an essential part in the fine coordination and regulation of the movement of the jaw. When we lose our teeth, we lose an important part that admits our jaw to move correctly. And when we extract a tooth, even endodontic, a tooth that has received a root canal treatment, this sensory motor function is completely lost or impaired when these receptors are removed after an extraction. And after we extract a tooth, nothing can replace it, not even an implant, because the implant hasn't got the periodontal ligament. So remember this. Residual roots may serve as abutment for removable partial denture or overdenture. And this is the last escape plan when we are in front of a questionable root. And so let's start from a very simple and easy case and on how to restore properly the one residual roots. This patient came at our office with this situation. She had two partial denture with clamps, with clasp, retained with clasp. But this teeth had this kind of problem. It started with a decay and then a fracture. It remained just a small part of hard tissue in place, and then it ended with a fracture. One solution could be extract everything, extract the root, and put the clasp on the canine, on the forward remaining sound tooth. This is the classical and traditional approach. But this could I don't practice anymore this kind of procedure because I found that this is I'm planning a new problem in this moment doing this way, because I'm putting a new clamp that generate horizontal force on the canine, and the problem that I had on this tooth after some years, in a few years, I'm going to find it on the canine. The solution that I'm suggesting you is another one, to run another way. Use this as a residual roots as an anchor point for our partial denture. So first of all, a proper root canal therapy. So with a proper insulation of the root, of the residual root, proper preparation of the root canal, and proper filling. After that, we have to create the post space to cement, to glue in our pivot. So since I use the thermofill system, I need to use this kind of burr to remove the guttaperca and the plastic carrier that is inside the root. If you use guttaperca only, you can use the Gates file in the same way, exactly the same way. The most important is to open as little as you need. Remove the dentin from the root. Don't weaken. Don't get the root get weakened. Don't let the root get weakened by your preparation. So make a hole as small as is necessary, not too big hole in the root, because otherwise it becomes too fragile and too weak, and it can be fractured by the post. I can choose a different kind of post to put into the root, starting from 7 millimeters and with a sphere block on the top, or self-parallelizing pivot with this basculating, oscillating sphere that has exactly the same diameter of the sphere block. Sincerely, I almost always use the smallest one exactly because of the reason I explained before, because I want to respect the hard tissue of the root, and I want to be less invasive as I can. And so after that, I pick up with the instruments. I choose the right size for my root. If I have a canine, I can use a bigger or longer pivot. If I have a premolar like I had, I prefer to use the smallest one. And since I have very few space, I choose the normal dimension that has a diameter of 1.8. After I created the space in the root, within the root, I prepare a lot the pivot. So I prefer to use a burr and modify heavily the shape of the post, always to respect the amount of the hard tissue that I have in the root. After that, I check the perfect fitting. If I have a perfect fit of the post inside the root, it must sit perfectly without friction on the wall of the dentin. Then I squeeze in the cement, starting from the bottom. This is a dual cement that I can that it can be self-cured and light cured. So I fill all the root canal. I fill all the root canal and the post and the outside of the post, and then I place rotating the pivot inside the root canal. After that, I have to check that everything fits in its place. So first of all, put as you saw in this animation. First of all, I show you again. First of all, put a centering ring if you notice that the female cap oscillates a lot over the sphere block. So put the centering device, the centering ring, then an isolation disc or a fragment of your rubber dam, because after that I'm going to put the resin over it. And the resin can get down here, but also down the sphere, down the sphere. So it can be impossible to remove the prosthesis. Don't worry, I'm talking a lot and faster about this procedure, but we are going to look at it very step by step in the few slides, in the next slide. So don't worry about that. Putting a pivot inside a crown instead of a clamp is a big advantage, because we are making a better restoration than a clamp. Since we are cutting down, in that case the crown was cut by the decay, but in many cases we have a residual root and we want to use it, and we cut off the crown and on purpose and place the pivot over the residual root. And this is a big advantage for us, because we have lowered the root crown ratio. This means that the forces developed by the prosthesis over the residual roots are lowered a lot. If we have a clamp, if we use a traditional clamp, our forces would be always centered in the crown, giving a big lever for the periodontal ligament. And it can create a periodontal ligament enlargement and the loss of the tooth at the end. And as you saw, I choose to start a green cap. The green cap is extremely elastic and gummy, has a gummy consistency. This means that it's very soft. So it has a physiotherapeutic action, like a physiotherapeutic action, because it gives the occlusal load an increase, a small increase. It absorbs occlusal and transverse stresses. It makes the load progressive because at the end the first shock is absorbed exactly by the occlusion is absorbed by the female cap directly, and we have a better root to crown ratio, as we saw. this gives a better rehabilitation of the periodontal fibers. And we are maintaining the pressure sensitivity, as we said. After the first period, if we saw that the system worked perfectly, after 6 months, for instance, we can change the hardness of the cap and giving a better and stronger retention if it is needed. Otherwise, we can still go on with the green cap. In the catalog, you can find different kind of retention. The color changes despite following the degree of retention. Why to use a plastic female cap over a metal sphere? It's simple, because a female cap works as an elastic body. This means that an elastic body has an elastic material like nylon, Teflon, has a compression area that compresses when it passes just right through the equator of the sphere, and then it releases because it releases after that. And we have retention not because of friction between the two components, but because we have an elastic part that gives and that goes under the equator. Moreover, we have a compression area right here that gives more shock absorption when doing the occlusion of the patient. If we are using a friction, rigid material that works by friction, the retentive area becomes smaller, because it's just the contact point between the two walls of the female cap and the sphere, and we have no resilience because it's a rigid material. And this is bad for the root because all the stresses are transferred to the root directly, and it's bad for especially for the metal part, because after a while it can be worn out. It can get worn out very easily. You lose a lot of material, and it's more difficult. It's more difficult to change the metal part than to change the plastic cap. So coming back to the clinical case, while we practiced the root canal therapy, and during the time that we placed the root canal, the pivot, sorry, we gave the prosthesis to the lab. In the lab, they cut away the clasp, the remaining clasp, the clamp, and added a new tooth. The new tooth must be turned upside down, the prosthesis. The new tooth has for sure a better aesthetic, because we have no clasp, no metal on the side, at the first site. And the tooth must be hollow in the bottom, because here must fit. We have to fit inside the female cap, the green cap. The lab gives us the denture with the empty body. We fill it with resin, liquid resin, and then put it right over what we have prepared before. So we have here the root with the root canal, proper root canal therapy. We place a protection from the resin to prevent the resin to go in the below the sphere, then the rubber dam, then the female cap, and then we put the prosthesis. The liquid resin will flow out, and we ask the patient to close tightly, because we don't want any alteration of the occlusal plane. And we can also use the patient sensitivity to be sure that everything is in its place, and we have no friction between the cap and and the prosthesis, because this system works well if everything lies on the gingiva, not on the residual root. We always remember that this is a retention system, not a supporting system. After that, we finish and polish everything inside, because we don't want any contact between the resin and the root. Otherwise, we lose all the resilience of the gum that we said before. The resilience also is useful because it goes exactly in the same way that when the denture rely on the gingiva, on the gum, it has there are resilience over the soft tissue, and we have the same on the gummy green cap. If we leave a resin that lay on the root, we have a rigid contact between them, and we lose every resilience. So be sure that there is no contact between the resin and the residual root. After that, after we have finished and polished everything, this is the situation. So we saved the canine here, because otherwise with the traditional system, we would have had a big clamp here, right here, embracing the canine. In this case, with this system, we don't have any clamp, any clasp. The aesthetic is excellent, and we are respecting all the biological and biomechanical requirement for that root, residual root. And so in 1 hour and a half, while I was working on the root, the laboratory was working on the prosthesis, and we had completed the case. After that, the patient in the lower teeth had a similar problem. So she knew the solution, she knew perfectly the solution, and we repeated exactly the same procedure. So after a root canal therapy, we cutted properly the residual root. We cutted, avoiding any surface, contact surface with the future prosthesis. We made the root canal post for the pivot. We put the pivot inside. And then, exactly as we did before, we relined with the resin, with the pink resin, the prosthesis. And so after that, the patient liked it a lot, and we made all the clamp disappear, because we used the residual root teeth exactly as a support, an anchor point for the partial denture. And this is a very simple, easy, and way to go to restore the residual roots for the patient. It's very cheap, but we are still having a very excellent aesthetic, and most of all, we are respecting the biological and biomechanical principle for residual roots. Okay, so this is a synthesis for the case. We saw the residual root restored with the spheroblock, but we have in the market, you can find also a pivot with equator on the head. Pivot with equator on the head means that we have a low profile attachment. This means that we can use exactly this to reduce a lot the space for the prosthesis. This means the more space we have for the prosthesis means that the prosthesis is stronger, because we have more resin on it. Exactly like this. Another way to use the pivot is to give a first aid solution for this patient that is very anxious, and she was very afraid to lose her teeth because of this severe periodontitis. So we decide, sorry, everything was moving as a very high level of movement. And so we decided to cut everything she break this in this part to cut everything and use the residual roots as an anchor point, and then to make a denture, a complete denture retained by the residual roots. But first of all, in the same seat, we wanted to allow the patient to get out with her teeth. So this was the bridge, the big bridge cemented on the root. And the plan was to cut all the crown at the gum level. This is the midline. Cut all the crown, make the root canal therapy in all the residual roots, prepare the post, the endopost for the endopivot for every root, cement it on every root, and then reline directly her bridge directly over those residual roots. So she could get away of the studio, of the office, with her teeth. We took an impression, of course. This was at the end of the chair seat. We took an impression of the patient, exactly like this. We took the impression of the patient, and especially of the roots that we wanted to save, and where these roots were more stable, the strongest roots, and we wanted to treat them with a Richmond-like crown restoration. So we made a custom-made pivot, not a standard from the market. This is the standard pivot, and in these roots we made the custom-made pivot with castable components. So these are the plastic pin, and we use them to take the impression, varnish with the impression adhesive, and then take the impression. So squeeze the impression material inside the root, and then place the post inside. And this is the impression of the endospace. After that, in the lab, they developed, this is the cast. In the lab, they just produced this Richmond-like crown with customized spheral retention. This kind of solution prevents from, in a better way, from fracture, especially, and from new decay from the roots, because it covers everything and gives a mechanical reinforcement of the root, while the direct root doesn't give any reinforcement for the root. And this is the situation. Over it, we are relining a completely new denture without the palatal plate. But since this is very tilted, this has a very bad angulation, we have to put this ring, a century ring, because we want the female cap to be on the axis of the perpendicular of the occlusion. In the lab, they develop with a proper analog for this system. And this is the final denture without the palatal plate, because we have a good retention over the root, so we don't need the palatal plate. And this is a big comfort for the patient. So this is the profile, the smile of the patient when she came with periodontal problem, with different problem, aesthetic problem, because the midline was completely out of its place. Since we have restored everything, we could be able to improve the aesthetics and the function of the patient, of this patient. So now let's see another situation. Oh, this is the end. Okay. Okay. Let's see another situation. So remember when in the first slide, when a tooth is hopeless, good, or questionable. Of course, we can make a partial denture, saving all these remaining teeth. But we have different problem, aesthetic problem, because we will have a lot of clamp showing during the smile. We have a different material in the occlusal plane, because we have resin, enamel of natural tooth. So the wearing rate with the counterpart, with the lower arch, is not equal in them during the time, during the time. A solution, there are many teeth that are good for extraction, like this one or this one, of course, but there are many questionable, like these 3 teeth or these 3 teeth. So the patient was wearing an old prosthesis, partial prosthesis, with clamps, and I think that this old partial prosthesis brought us to this situation, because the clamp moved the crown or moved the teeth during the year, so it ruined the enamel here, it ruined the tooth right here, it fractured probably in some months ago. But for sure, we have a different material in the occlusal plane. So we have natural teeth against resin, like here, natural teeth against resin, like here, or natural teeth against resin, like here. So the occlusal plane is completely lost, because somewhere the tooth completely worn out the resin, but not in the same way. The diagnosis must be updated now with new knowledge that we have. So these 3 teeth, 2 canine and 1 premolar, can be used again in a good way. And this is the upper arch. So first of all, let's check the occlusal plane with a wax wall, and it must be parallel to the binocular line. And after that, we give this information to the lab. In the lab, we have this situation. So what can we do? We can, of course, do a lot of things. First of all, root canal therapy, a proper root canal therapy, because otherwise, if we are not good in root canal therapy, we are losing time, because these teeth can develop infection, granuloma, periodontal, periapical infection, and we are condemning this tooth to extraction in a few months or years. After we made proper root canal therapy, we can use it as a sound and strong pivot anchor point for our prosthesis. First of all, we have to put down the root to crown ratio, lower the root to crown ratio. This means that the forces are lower on the teeth. The occlusal forces are lower on the teeth, because the center of the movement is low here, not up here, like if we had put a clamp on it. After that, we remove everything from the root canal space, and we are preparing this for the precision impression, as we did in the previous case. Precision impression that must be taken with a plastic pin that must be scratched and scraped to give more retention, and varnished with the adhesive like this, exactly like this. Then we squeeze inside the root canal the impression material with flow consistence, and then put the root canal inside, the root pivot, sorry, inside. After that, we take an impression of the whole mouth, and you have here the spikes of the pivot. In the lab, and we are giving this to the lab, but this work is the definitive one. It will take. We wanted we wanted to give more attention to this case, and because the patient was very demanding patient. And this impression was taken apart to produce the definitive restoration. In the meanwhile, we went on with the temporary restoration that was made like this. So an extemporary express denture, overdenture, for the upper arch and for the lower arch. It was digged to leave the space for the pivot, because in the studio I had to reline it on the sphere, right over the sphere. And as you saw before, first of all, I want to reduce the volume, the shape, to reduce the shape of the pivot, to give more resistance to the root, and then first of all make the right space, and not too much, otherwise we are going to crack in a short time the residual root, and then glue in the pivot. That must be as low as possible. So if it doesn't get the lowest position, then try to cut away again and again the metal from the pivot until we reach the lowest position that we can have. After that, the laboratory, give us the denture, the temporary denture, and this is how you have to reline the denture over the root. The most of the attention must be paid to avoid any contact, any kind of contact between the cap and the resin of the clamp of the denture. Otherwise, all the occlusal load are relying on the root, not on the gum. Always remember that the root and the pivot are retention system, not they are anchor or retention system, not supporting system. They are not implant. This is not an overdenture over a bar. So the only function is to take in its place the denture. So you don't want any contact between this and this. How can you do it? Take some lipstick. This is a lipstick, but you can use also a toothpaste. It is white and it is easy to check it. Use a toothpaste or a lipstick, put it on the female cap, and then place the denture over it without any resin, before putting the resin. If you see some stain or some stain from the lipstick or or from the toothpaste, then you have to dig it away. Check it as many times as you can, until you don't have any trace of the lipstick or of the toothpaste. When it came out of the mouth, completely polished, completely clean, without any trace of toothpaste or lipstick, then it's ready to be relined. Also, you can check by asking the patient to close the mouth, and if he is feeling normal, it's okay. Usually, he feels that something is wrong if the denture touches or lying or is lying over the female cap. Then prepare the resin and fill all the empty spaces with resin. And the first step before you put here, I go back a little while. Always remember to put a protection disc or some fragment of rubber band. Rubber dam or glove, or a piece of glove. Otherwise, the resin will go under the undercut and after the polymerization, it's impossible to, after the curing of the resin, it's impossible to extract the denture after the polymerization. So remind it. I always stress this point because it's very, very annoying and time-consuming to extract the denture if the resin has polymerized under the undercut. So put the resin, put the denture over the cap you had placed, and then ask the patient to close as strong as he can, and then stay in that position until the resin has completely polymerized, cured. After that, you can use also a crown remover to remove the denture, because it can be a little bit hard. And then you have this. The resin didn't went in under the undercut right here or right here, because we used the protection disc that remained in the denture. You see the shape of the protection disc, the plastic transparent protection disc right here and right here. Okay, then we go to the lab again to finish and polish everything. And the most important part here, of course, polish everything, but remove all the resin that can be in contact with the root, because we don't want any rigid contact between the root and the resin. After that, this is, I remember, after that, this is the temporary prosthesis. I want to remember this. Okay, I reline the same way the upper part. So protection disc, female cap. This is the day of the extraction. So the patient came in with that condition that we saw in the beginning and get out with a new condition, because I had this denture before to start the extraction and before to start the root canal therapy. So check that there is no lipstick in the denture, and then check again, asking the patient, fill all the empty spaces with resin, and then we have the denture with the protection disc in the new relined resin. The excess of resin must be removed, and this is the upper part finished. Oh, sorry. Okay. We started from that, the patient came from that, and then after that, the patient came out with this. Why I say 3 seat? Because the first seat was to register all the dates, all the datas, and the second was to check the camper and the binocular plane, and the third was to make all the job. Perfect. After that, we wanted to go on with the job to go to the definitive one. We saw that after, so we want to make a customized solution. So we want to take the impression of the root canal. We take the plastic pin, varnish it, and put it in the root canal. After that, every plastic pin is in its place. That we saw. We already saw this. I want to show you it again. We take also the lower part, and we have the 2 impressions. With these 2 impressions, the lab give us the wax wall to register in a better way the occlusal data, all the occlusal data. We put it in the cast. After that, we have we are making a try. This is wax, and we want to check the aesthetic of the denture in the mouth of the patient with the wax and with the teeth mounted, because this must be the final result. The wax of the wax to give support for the teeth. We check the occlusion, vertical dimension, the aesthetic, if the patient likes it or not, the phonetics, if everything is working well or not. After we checked everything, we can go on with the metal components going to the root and with the resin part. So this is a castable one. So everything are these are the castable pin, the plastic castable pin that goes inside the root. And after that, with the technician with the wax, put the wax over that. With this system, it's possible to put the ball, the attachment, wherever we want, because we don't need to follow the root axis as we have to do when we fix the direct pin. Because we can cut in two parts, the part that goes inside the root canal and the part that goes with the ball, with attachment. So we can place in a more convenient place the ball attachment out of the aesthetic zone, for example, perpendicular to the occlusal plane. So the wearing rate of the sphere is preserved. Or we can put more palatal or lingual. Exactly like this. They are all perpendicular to the occlusal plane because we mounted it with the parallelometer. After that, we remove the temporary pivot. We removed because we can do it because we didn't made any scratch on it. So the cement is a temporary one. So you just need to twist it, and since it's polished, completely polished, it goes away. And then we cement the definitive one. After we cement the definitive Richmond-like attachment, we have to check that there is no contact, no friction between the root canal and the root and the metal part, because we want it to sit perfectly passively. So we can check with fit checker, with powder check. So if we see contact, we have to dig it out. So it can go exactly till the end to its place, all the way down to its place. After that, I etch the canal, the root canal, with etching, with acid etching, and then clean, rinse with water, then dry with paper points, and then I squeeze inside the root the cement, the dual cement, so light cured and self-cured cement, self-cured resin cement. And this is ready for the definitive denture. So why I'm not using any framework inside the resin? Because if I have more resin in the thickness of the denture, I have more resistance. If I put some metal inside, the resin part is small. I have a thinner part of resin, so it can be the weakest point from where it can start a crack. How to take the impression with this? In the catalog, you can find a proper dedicated transfer for this equator, for this spheroblock. It has a space. It's made like this. It has a space for the female cap, normo or micro, if you have a normal system or a micro system. And then some kind of umbrella that gives the retention. You have to squeeze the impression material right over here, right down here. So when you pick up your impression, it snaps out from the ball. In the lab, they are using an analog of the pivot, so it's not analog of the implant, but analog of the pivot. They put it on the impression, and then when they have the stone, when they cast the stone, they have the exact replica of what we have in the mouth. Take the impression also of that one. Okay, I see that there is a question and answer. If you agree, I can try to understand. Is it more affordable than precision attachment? Yeah, after that, we will ask to Niccolo, because he's more prepared to give you the answer to this question. If it's more affordable, you mean by price, but if it's cheaper. Okay. Well, it is a precision attachment. It is a precision attachment attached to a root. It maintains the precision, but we are not using an implant. After that, I squeeze inside the transfer, inside the umbrella of the transfer, the retention point of the transfer, the impression material, and then I take the impression of everything. After that, in the lab, they put the analog inside the female cap, inside the transfer. They have this kind of mask, silicone mask, that gives us the final volume of the denture, so I know where to put everything. The metal frame, I know where to put the metal frame in. That must stay inside this volume. This is a more technical part. I skip this part because we are all dentists and we are interested in it, but not so much. So this is how it looks like before the resin. Then the technician puts the female cap inside the framework, and this is the final denture, the definitive denture that has a support that is supported by the gingiva and retained by the endopost. As we saw before, we have to choose the right retention. For instance, if we have a lot pivot, it's better to use a yellow cap because we have a lot of retention. If we have less elements to give retention, it's better to use the pink caps that has a stronger retention. So this is another situation, and this is another chapter in which we use residual roots as a temporary solution, waiting for implants. Till now, we saw cases where patient asked for treatment without implant, or patient that asked for a cheap treatment, and those were definitive solution over that route. In this following case, we are using the root as a temporary solution to waiting for the implant introgression. So we had these two remaining roots, and we have planned implants on the left side and on the right side, but we didn't want to use a complete denture that could compress the implant after we put on it. So we use these two incisors, central incisor, to give retention to the prosthesis, to the temporary prosthesis. And now the procedure is always the same. So we have to make a proper root canal therapy, and then put the endo pivot inside. After that, always put a protection from the resin, from the liquid resin. Otherwise, the resin will flow down the undercuts and it's impossible to remove it. I say it again, once again. And then in the lab, they have produced, they have enlarged. You remember, this patient had a partial denture, and they completed with the central incisors. And the same seat, when we put the implant over beside the central incisor, we relined the denture over that. So it was possible to wait for the integration of the implants and then made a delayed load. Another situation in which we waited for the implants, but we used this route as to save bone for the implant. In this case, we can consider this case as a split mount, because we have two parallel situations: one with the clamp and one with the pivot inside the root. So the choice is to use when we have to choose between the clamp and the pivot, we have to be aware also of this, because the clamp can damage the periodontal ligament, and it can be impossible to put an implant in this place. When instead, if we use a pivot inside the root, we can save bone, we can save the bone quality and volume and amount of bone for the next implant. What I mean with this, after this is worn out, and this is a temporary situation, so I don't mind if it's going to be decayed. But at the first sight, you can see, at the first glance, you can see that here the gum level is maintained, and the root is perfectly sound and strong from a periodontal point of view. But this one that had the clamp has completely lost the bone around it. And we can see in a better way with X-rays. So this is the one with the clamp, and this is the one, sorry, this is the one with the pivot, and this is the one with the clamp. After some months, the root with the pivot you see in the CBCT cone beam, you can see the root with the pivot has maintained the cortical, the vestibular bone, and the basal bone. Because for all the things that we have said, because we have put over it a gummy female cap that preserved the forces, the occlusal, the stressing forces over the root. We lowered the root to crown ratio, so the stressing point is not up here, but the lever is lowered. So the lever on this root is less than on residual root with the clamp. And so this is a good implant site, a post-extractive implant site. This one, no more, not anymore, because the bone around it is completely lost, even not only the vestibular and the cortical bone, but also the basal bone. So when we want to put a clamp, always think before to put a clamp. Always think, can I put a pivot instead of it? What is my aim? Save the bone, save the root, and then make the right choice. After that, so a short slide of the implant procedure. So we put the implant. This was the implant site where the root was saved with the pivot, and this is the not more the tooth, sorry, with the clamp that is no more useful for the implant. And in fact, in this part, the last implant that we could put was this on the lateral incisor. We took the impression, and then we made an immediate load. This is a particular procedure that allows us to make an immediate load of the implant. And this is in the mirror, so you can see here we could be able to put the implant in the most rear back part of the arch, and here there was the root, the teeth, the premolar with the clamp, and so it wasn't possible to put an implant over here. After a few years, this is the check of the situation, and this is the final denture. So as you can see, after the healing, here remained very few bone to put an implant, and this was the place where there was the bone, the root with the clamp. With this, I end up my presentation. I very thank you to be so kind to listen to me, to my presentation. I hope that the cooperation with RAIN 83 will follow on with other arguments, and I invite you to follow the new progress and the new development inside RAIN 83. That starting from what we saw, that was the very beginning of the company. It was born in '83 with exactly with the root canal pivot, and today we are working. We have developed now since a few years, we developed a system over implant that has a wonderful solution for fixed prosthesis over implant.